Hey guys, let's see about carcinoma of the maxillary sinus. It is more common in 40 to 60 years of age, more common in males. Etiology, important etiology is hardwood furniture. This increases the risk of adenocarcinoma of the ethmoid sinus and also other risk factors like nickel refining industry workers, leather workers. Most common type of carcinoma of paranasal sinus is squamous cell carcinoma, and it is more common in maxillary sinus. Complaints: the patient can have nasal stuffiness or obstruction, blood-stained discharge, facial pain, and epiphora, etc. The spread of the tumor can occur by direct means or bloodborne means or by lymphatic means. Directly, it can through the medial extension, it can involve the nasal cavity, and it can also involve the anterior and posterior ethmoid. Inferiorly, it can involve the hard palate. This causes pain, symptoms like dental pain and losing of teeth and ill-fitting dentures. Posteriorly, it can spread through the pterygopalatine fossa, sphenoid sinus, and nasopharynx. Posteriorly, it can also affect the intratemporal muscles, causing trismus. Superiorly, it can spread into the orbit, causing proptosis. Anteriorly, it can spread through the cheeks. Bloodborne spread can be to lungs or bones. Lymphatic spread is seen in late stages, and it involves the submandibular and upper jugular nodes. Investigations for carcinoma of maxillary sinus involves CT scan and diagnostic national endoscopy. Classification: we have Hornman's classification. Here we draw an imaginary plane from connecting the medial canthus of the eye to the angle of mandible. From the medial canthus of the eye to the angle of mandible. If the tumor is above this plane, the patient has poor prognosis because it usually presents in late stages, and also resection is difficult. Letterman's classification: we draw two horizontal lines, one at the floor of the orbit and other at the floor of antrum, and it divides into three cavities: suprastructure, mesostructure, and infrastructure. And suprastructure has poor prognosis. TNM staging: we have T1 where there is no bony destruction, only mucosal involvement. T2, there is bony destruction of medial meatus or hard palate. T3, we have floor or medial wall of the orbit involvement, posterior wall of maxilla and pterygoid fossa involvement, and ethmoid sinus involvement. In T4, we have sphenoid or frontal sinus involvement, cheek, skin, pterygoid plates and orbital contents and cribriform plates involvement. N staging: single IPSI less than 3 cm is N1, N2 is IPSI or bilateral, all less than 6 cm, and N3 is more than 6 cm. Treatment for T1 and T2 tumors is surgery mainly. T3 and T4, we have combined modality treatment with radiotherapy.